Today, in What's New in 22Q, we are diving deep into a topic that, well, it sits right at the heart of health management for individuals with 22q11.2 deletion syndrome, congenital heart defects.
Yes, these defects are arguably the most urgent health challenge.
And they're noted as the primary cause of mortality in childhood for this community, right?
Sadly, yes. That's why our focus today is so important. We're digging into the findings from uh, really a landmark piece of research.
Okay.
It's a systematic review and meta-analysis. The lead author is Karina Sauter,
Soccer, got it.
and the paper's title is Congenital Heart Disease in 22q11.2 Deletion Syndrome, a meta-analysis and a systematic review of the literature. It's just been accepted in the Journal of Medical Genetics for 2025 publication.
Okay, 2025. So for those of us following the research, why is this study such a big deal? I mean, we already know the risk for heart issues is high in 22q.
That's a fair question.
Mm.
We knew the risk was high, yes, but the actual numbers we were using, they were often, let's say, a bit skewed.
Skewed how?
Well, the problem was something called selection bias. A lot of the older data came only from highly specialized cardiology centers.
Okay. So places where you'd only send kids who already have pretty serious known heart problems.
Exactly. So if you only study patients in those centers, you're naturally going to overestimate how common these heart defects are across the entire 22q population.
Right. Your sample isn't representative of everyone with a deletion. It only represents the most severe end of the spectrum, perhaps.
Precisely. And that's what this new review by Sauter and her team tackled head-on. They did a systematic search, pulled together 7 high-quality studies. We're talking data from over 2,500 patients.
Wow. That's a lot.
It is. And crucially, they specifically excluded studies that only recruited patients from those specialized heart centers.
Okay, so they actively filtered out that bias.
Yes. The aim was to get the most realistic, generalizable prevalence numbers we've had so far. A true picture, of the cardiac reality for the wider 22q community.
That makes sense. That methodological difference gives us, well, a lot more confidence in these results. And the big picture finding, even with these more accurate numbers, the link between 22q and CHDs is still incredibly strong.
Oh, it's undeniable. Absolutely. 22q11.2 deletion syndrome is still considered the second main genetic cause of congenital heart diseases overall.
Right.
And this study confirms that even heart defects that are really, really rare in the general population, they're significantly more common in people with 22q.
And it's not just a childhood issue, is it? You mentioned mortality.
That's a critical point. This isn't just about getting through infancy or childhood. Beyond that, sudden death and heart failure are unfortunately frequent causes of mortality for adults with 22q. The need for cardiac vigilance is truly lifelong.
Okay, lifelong vigilance. Let's get into the specifics then. The numbers they pulled from this combined analysis, this is where it really hits home for clinical practice. What do they find were the most common defects?
The one that came out on top was tetralogy of Fallot, often called TOF.
TOF, right. That's quite a complex one.
It is. It involves 4 different structural problems in the heart. Essentially, without surgery, the body doesn't get enough oxygen.
And the prevalence.
Yep.
What percentage of individuals with 22q in this realistic data set had TOF?
The pooled prevalence was 20%, 1 in 5.
20%. And how does that compare to the general population?
It's staggering. The risk is increased almost 600-fold, 600 times more likely if you have the 22q deletion.
Wow. 600 times. That really paints a picture. It's like, if finding it normally is like searching for a needle in a haystack, for the 22q community, the needle is practically sitting on top.
That's a good way to put it. It really highlights how strong that genetic link is. After TOF, the next most common one they looked at was ventricular septal defect, or VSD.
Right, a hole between the bottom chambers of the heart.
Yes, exactly. That had a pooled prevalence of 14%. Now, VSDs are more common generally, but still, for someone with 22q, the risk is up to 50 times higher.
Okay, still significantly elevated. Now, you mentioned some defects where the risk compared to the general population just skyrockets. Let's talk about those.
Right, and this is where the data really screams for mandatory screening. One of the most dramatic increases is for interrupted aortic arch, IAA.
Okay, what is IAA?
That's where the aorta, the main artery leaving the heart, isn't fully connected. There's a physical break or interruption. It was found in 10% of the individuals in this analysis.
10%. But IAA is incredibly rare otherwise, isn't it?
Extremely rare. In the 22q population, the risk for IAA is increased by about 2,000-fold.
2,000?
Yes, 2,000 times more likely. That makes it one of the conditions most strongly associated with the deletion.
Okay, if 600-fold for TOF was striking, 2,000-fold for IAA. That just underlines that you simply cannot assume a child with 22q doesn't have a heart defect until you've thoroughly checked.
Absolutely. And there are others in that high-risk category, too. Truncus arteriosus communis, or TAC.
TAC.
Yes, that was found in 9%. The risk there is about 1,000 times higher. And pulmonary atresia with VSD, also 9%, which is up to 900 times higher risk.
So multiple complex defects all clustering around that 9–10% mark with incredibly high relative risks.
Correct. And even the one with the lowest prevalence they specifically highlighted, atrial septal defects, ASD.
A hole between the top chambers.
Yes, that was at 3%. But even that is still 20 times higher than in the general population. The message is crystal clear. Pretty much every type of CHD is significantly more frequent.
There was also mention of aortic arch anomalies, AAA. They had a really wide prevalence range reported, didn't they? Something like 2% to 27%.
That's right, a very broad range. It probably reflects some inconsistency in how they're diagnosed or looked for. But the really crucial point the authors made about AAA is that these anomalies can often be completely asymptomatic.
Meaning no obvious symptoms.
Exactly, for a long time.
Yeah.
They can be structural issues that don't cause immediate problems, so they can easily be missed in an early checkup if the doctor isn't specifically looking for them with the right tools. They can be hidden.
Okay, so that brings us squarely to the practical side. We have these solid, realistic numbers now. What does this mean for families? If a child gets a 22q diagnosis but seems healthy, maybe hitting milestones okay. Is cardiac screening really mandatory? Or is it adding stress?
It's a valid concern, the
Yeah.
stress factor.
Yeah.
But when you see risks like IAA needing urgent surgery being 2,000 times more likely,
Right.
and knowing that things like aortic arch anomalies can hide without symptoms, the conclusion is unavoidable.
Yeah.
The paper's #1 most critical recommendation is crystal clear. Screening for congenital heart disease is mandatory. For all children diagnosed with 22q is 11.2 DS, no exceptions.
Okay, mandatory screening, and that allows for...
It allows for timely intervention. It lets doctors tailor treatment for the specific CHD before a crisis happens. It's proactive care based on a known, very high genetic risk.
Makes sense. What about beyond childhood? You mentioned lifelong vigilance. Does the study speak to long-term care needs?
Absolutely. The authors strongly emphasize that clinical guidelines for managing 22q need to explicitly include detailed plans for ongoing cardiological assessment.
Not just a one-off check?
No, definitely not. It needs to cover targeted therapy if needed, and crucially, continuous long-term heart care right across the lifespan. This is about adult health and longevity too, not just surviving childhood.
And for those tricky aortic arch anomalies, the potentially hidden ones, is there specific advice on how to screen for those?
Yes. They recommend screening all infants using a detailed echocardiogram. That's a high-resolution ultrasound of the heart that's needed to spot those subtle structural issues.
Okay. And for adults, maybe someone diagnosed later or who missed that detailed infant check.
For adults, particularly if there's any question, the evaluation might need more advanced imaging, like a cardiac MRI or a CT scan, to really get the full picture.
Yeah, let's flip this around. Given how common these specific heart defects are in 22q, what does this mean when a baby is born with, say, TOF or IAA, but doesn't have a 22q diagnosis yet?
That's the other side of the coin, and it's incredibly important for diagnosis because the link is so strong, especially for TOF, IAA, and truncus arteriosus.
The ones with those thousand-fold risks.
Exactly. Genetic testing for 22q11.2 deletion syndrome should really be a standard part of the diagnostic workup for any baby, any patient, diagnosed with one of those strongly associated heart defects.
So the heart defect itself becomes a major red flag pointing towards a possible 22q diagnosis.
Yes, it's a vital clue that can lead to the comprehensive multi-system care that someone with 22q needs, much earlier than might happen otherwise.
Which implies a need for broader awareness in medicine.
Definitely. Doctors across different fields, cardiologists, yes, but also psychiatrists, ENTs, immunologists, they all need to be aware of 22q and when genetic testing is warranted based on the pattern of health issues.
And for families receiving this information.
Always, comprehensive genetic counseling is key. Families need clear, supportive information about what the diagnosis means, the natural history, the causes, and any risk for future pregnancies.
That support is so important. And just a quick note here, this deep dive is brought to you by 22q11 Europe, the European Association supporting families living with 22q11 Deletion Syndrome.
You know, what's really powerful about this Sauter study isn't just confirming the high risk. It's that we now have these robust, bias-corrected numbers.
The 20% for TOF, the 2,000-fold for IAA.
Exactly. These aren't just academic figures. They are solid evidence. They give families, patient advocates, and clinicians the foundation to say, look, the risk is demonstrably this high. Therefore, mandatory proactive cardiac screening isn't optional, it's essential.
And that care needs to continue.
Absolutely. It provides the basis to demand standardized, lifelong cardiac follow-up plans, ensuring everyone with 22q gets the heart care they need for their entire lives. It takes the guesswork out and replaces it with data-driven certainty.
A really crucial update for the community. Thank you for breaking that down for us.
My pleasure.
Thank you for listening to What's New in 22q, produced by Dr. Stefan Elias for 22q11 Europe. Take care and talk to you soon.